So, very good evening to you. It's a pleasure being here and grateful to the organizing committee for giving me this opportunity. I'm going to speak on super selective intra-arterial chemotherapy for retinoblastoma, when and how. I come from the All India Institute of Medical Sciences in Delhi. So as we all know, the goals of therapy of retinoblastoma are life salvage, globe salvage, and vision salvage wherever it is possible. Of late, there has been a paradigm shift towards globe salvage treatment modalities in retinoblastoma that has helped us in conserving a lot of eyes that have otherwise would have had to undergo enucleation. So what are these treatments? One of these treatments that is now becoming very popular all over the world and is also being used in some centers in India is super selective intra-arterial chemotherapy. And essentially what this entails is delivery of targeted chemotherapy to the eye via direct cannulation of the ophthalmic artery. So this was a landmark paper published more than 10 years ago, and this was the New York group with Dr. Abramson and Dr. Gobin who first described their experience of intra-arterial chemotherapy for management of retinoblastoma. And after that, there has been an interest all over the world in incorporating this treatment into the routine management of retinoblastoma cases. Now, why IAC is the question. So first of all, we all understand that whenever we try to save an eye with chemotherapy, if we are giving it through the intravenous route, we are exposing the child to the dangers of systemic toxicity. And here the retinoblastoma is just limited to the eye. So if we are able to deliver targeted drug just to the tumor and avoid the side effects of systemic chemotherapy, that would seem to be an ideal situation. So this IAC enables us, it offers us the chance to use high concentration of the drug at very low doses. And when we say super selective intra-arterial chemotherapy, it was initially devised by the Japanese and later modified by the American group. And what they actually do is insert a microcatheter right into the ophthalmic artery, and thereby they're able to deliver the chemotherapy drug into the artery of ophthalmic artery that just goes and then enters the tumor. So now, obviously, not all cases of retinoblastoma can be given intra-arterial chemotherapy. So here the question is that who can benefit from intra-arterial chemotherapy and what are the important considerations? So first is a careful case selection, and the second is that we need a multidisciplinary team that consists of an ocular oncologist, an interventional neuroradiologist who can actually do the procedure of intra-arterial chemotherapy, an anesthetist and a pediatric oncologist to look after the systemic issues that may arise because of the procedure. So when it comes to the exclusion, we have a checklist. Obviously, if it's advanced retinoblastoma, there's already anterior chamber invasion, there's secondary glaucoma, phthisis bulbi, aseptic cellulitis, optic nerve invasion, or frank extraocular disease like we already have in many of the advanced cases of retinoblastoma who come to us. The tumor has already spread beyond the eye, so there is no question of trying to save the eye. Here you want to save the life of the child. So in such cases, we cannot recommend intra-arterial chemotherapy. Now the real challenge comes in the development of setting up a multidisciplinary team. Like I told you, it is a kind of collaborative work between an ophthalmologist, a neuroradiologist, and a pediatric oncologist. So luckily, at All India Institute of Medical Sciences, we have a team where we have been doing this procedure for almost the last 10 years. And we have a very skilled interventional neuroradiologist who's helping us develop this facility at our center and providing it at a very nominal cost to our patients. So here's a short video where I will just show you how this procedure is done, and I would like to acknowledge the neuroradiology lab where this video has been shot. So the child is, of course, first under general anesthesia. The procedure is done. These are the things that are used for the procedure. There's a guiding catheter, there's a guide wire, there's a microcatheter. And here you can see, under fluoroscopy guidance, the femoral artery is actually punctured on the side of the ophthalmic artery. And through the femoral artery, there's a catheter which goes, if you remember your anatomy, it goes right through the aorta. Here it's going through the abdominal aorta, the thoracic aorta, and then, if you remember, the ophthalmic artery is a branch of the internal carotid artery. So from the aorta, it has to actually reach the internal carotid artery. And from there, then, it has to the catheter has to actually reach the ophthalmic artery. And you can imagine this is a child, how thin and friable the ophthalmic artery of the child would be. So how much of skill and expertise is needed on the part of the interventional neuroradiologist. So what you can see over here is that a dye is, once the catheter is in position, a dye is being injected. This is the cerebral arteriogram, and it shows the vascular supply, because sometimes children have an aberrant vascular supply, and the ophthalmic artery may not be arising from the internal carotid artery. So the whole idea is to understand the angioanatomy before actually injecting the drug, to make sure that it is entering the correct place. So here you have, this is the catheter, it is going in, and once it is in position, then it is placed there, the ophthalmic artery is hooked. Here you can see the dye is being injected, and this is showing that it is right inside the ophthalmic artery. Melphalan is the most common drug that is used, although we also use some other drugs. It is freshly prepared at the time of the procedure, and then it is infused over a period of 30 minutes. So this is briefly how the procedure is done. And why do we use melphalan? Because in vitro studies have showed its greatest effect on retinoblastoma cells. Nevertheless, systemic use of melphalan is limited because of severe myelosuppression. It cannot be used through the systemic route, although it is very efficacious, and hence it is a drug of choice to be used through the intra-arterial route. Now, this is how we prepare. Broadly, age-wise, the concentration of melphalan, but mostly children with 1 to 3 years get a dose of 4 milligram. And sometimes we need multiple sessions. In fact, usually one session doesn't suffice. We do go up to 3 sessions. Sometimes we also top it up with other drugs like topotecan and carboplatin, but the initial drug of choice is melphalan. So this is one case of a 2-year-old boy. He had a group B retinoblastoma. Initially, the cases that we did were all one-eyed patients, and they were kind of desperate cases for globe salvage that had failed systemic chemotherapy. Now, of course, we are using it more commonly. We are offering it even as a primary treatment in some of the cases. So in this patient, again, you see over here that, the tumor had failed systemic chemotherapy. It was right at the posterior pole. And this is the response that we had after IC. It was all stable then at 2 years of follow-up. This is another similar case of a 2-year-old girl that benefited from this treatment. The tumor responded to IC. It had not responded to intravenous chemotherapy. This is another such case. You can see the tumors regressed on the top after systemic chemotherapy, but this tumor that was still active then was treated with IC. Of course, one has to be very wary of complications, and it cannot be done, kind of without the backup of a good pediatric oncology setup. There can be anesthesia-related complications, there can be vasospasm, thromboembolic phenomena, there can be ocular complications, there can be a hematoma formation at the femoral artery. So one has to be ready to tackle these kind of complications. It's a technically challenging procedure, and so all these things have to be explained to the patient. Another child who developed a third nerve palsy after the procedure, after day 7, but most of these things, they resolve on their own. Like in this case, after 3 weeks, the child was doing absolutely fine. Now, technically, like I mentioned, it's a very challenging procedure, so there are instances of failure of cannulation because of small artery of the ophthalmic artery. It could be a steep takeoff from the IC, and sometimes there's an alternate vascular supply to the eye through the middle meningeal artery. So this is one article that we recently wrote for Dr. Yanov's book on intra-arterial chemotherapy in retinoblastoma. So you can check out on more about this procedure from here. And for an international perspective, we also have this intra-arterial chemotherapy in our upcoming book, Global Perspectives in Ocular Oncology. That's my colleague from Harvard Medical School, Dr. Mary Arano, who has co-edited this book with me. And before I end, just 2 important announcements. Tomorrow we have an inaugural session for the Eye Cancer Society of India. So if we invite all ocular oncologists, ophthalmologists, and everybody who's interested in learning more about eye cancer treatment or in contributing to the awareness of eye cancers in India is most welcome to join us. We would be delighted to have you there. We also have an upcoming webinar which is going to be the first virtual symposium on the Asian retinoblastoma group. My colleague Ido Didi Fabian has joined me in arranging this webinar, and this is going to be held on January 15, 2023. We have many countries all over Asia where experts would be joining us either as presenters or as panelists, and I hope this is going to be of interest to all of you. This is the link that is available. Thank you all for your